Hi everybody, I'm Dr. Yamal Patel. I'm a gynecologist, an obstetrician, and an advanced minimally invasive surgeon. Today, let's talk about one of the most common procedures done by a gynecologist, and that would be hysterectomy. And in today's talk, we'll be talking about this procedure being done laparoscopically. So, total laparoscopic hysterectomy. What are we going to be discussing? We're going to be discussing the definition, we're going to be discussing the types, something about the consent. Then we're going to be talking about the critical steps, some variations, and how to end up with the safety tests and role of salpingectomy, etc. in hysterectomy. We're also going to be discussing the steps of hysterectomy and the rationale. Where to cut and why, where not to cut, where to be cautious. If you're going to be preserving the ovary, then how to prevent future torsion, how to close the vault and prevention of secondary hemorrhage, how to secure the uterines, how to prevent ureter injury, why the right is more injured than the left, and is ureterolysis necessary in every case. So these are some of the questions that we'll try and address in this talk. So hysterectomy is basically removal of the uterus, and it's the most commonly performed major gynecological surgical procedure. It can be done by the abdominal route, it can be done by the vaginal route, it can be done by the laparoscopic route. It can be total or subtotal, total being removal of the uterus corpus along with the cervix. And subtotal means removal of the uterus but leaving the cervix. It can be simple or radical. Simple is usually done extrafacial with removal of the uterus and cervix and then closure of the vault. Now, what about radical? Radical is basically combining two concepts, which we are not going to be discussing today in depth, but just to understand, it is an organ extended surgery, which means the uterus with the surrounding parametrium, adnexa, and the upper part of the vagina, and the lymphatic territory surgery involving sometimes the pelvic or the para-aortic lymphadenectomy. That's not what we are classifying or discussing today. We have different classifications of the radical hysterectomy as well. So let's start with the basics of prepping for a hysterectomy. Number one, have the right indication. So basically you've looked at the patient, examined the patient, discussed the options of treatment for the pathology that the patient has, and then you come down to deciding that this patient will need a hysterectomy. Then the next step is to discuss with her the options of hysterectomy. And you would say that, yes, we have the option of open hysterectomy versus the laparoscopic hysterectomy versus the potential of vaginal hysterectomy, and let the patient decide, giving them the pros and cons of each method. Now it comes down to, we've agreed on a hysterectomy being done laparoscopically. So let's discuss the consent. In the consent, it's very important to ensure the following important points. Number one, you've discussed the indication. It should be a procedure-specific indication, consent-informed consent. It should be explaining the risks involved, the alternatives available, what are the issues with omission of this procedure. For example, if fibroids causing extremely heavy periods, then what are the issues with omission of this procedure. It should be informed, mutually agreed, and it should be not coercive. It should be signed and witnessed, and it should be discussed in a language understood or in front of a person who can help to translate it to the patient. And then the patient signs off the consent. We now go in to the theater ready for the hysterectomy. how do we position this patient? Most of the times for laparoscopic hysterectomy, we would position them in a dorsal decubitus position, in a semilithotomy or a Lloyd Davis position with the legs a bit straightened out, with a space in between the legs to allow for possible assistance from below. It should ideally be done under general anesthesia, with the legs in the stirrups, arms along the side of the body, not on the sides this way, tucked in, because this way, if you stand, the surgeon stands here, he's going to require it to be extended, and that can cause nerve injuries to the patient. So it should be arms tucked in by the side of the patient, with the buttocks slightly extending over the edge of the table, so just beyond, and with the bladder drained, the position of the first, second, and the surgeon himself. The surgeon, the first assistant, second assistant positions to be checked, and then the procedure begins. Initially on entry, the procedure begins with the patient in the flat position, and you decide on your port placement based on the pathology. So a uterus, as it grows bigger, wider, might require different positioning of the ports. We next come to uterine manipulation. Well, there are various types of manipulators, and we're not going into the details, but manipulation helps in a certain number of ways to give us better exposure to the surgeon, and it also helps with pushing the uterus away from the ureter, and hence might be in a way able to reduce the risk of uterine injury, ureteric injury. But you can either manipulate from below with an assistant from below as a second assistant, or you could have manipulation from above where the uterus is lifted up by either a myoma spiral or a tenaculum for that matter, and pull the ureter away from the uterus. It is optional though, and many times controlled by second assistant or by the surgeon or first assistant himself if it's from above. You then establish the pneumoperitoneum, which can be done by any of the entry techniques, the Verres, the direct trocar entry, the optical entry, or the Hassen's entry, depending on the clinical need at the time. Primary sites of entry for the optical trocar could be intraumbilical, supraumbilical, infraumbilical, Li Huang's point, which is slightly above, maybe the Palmer's point on the side if there are adhesions from previous surgery, or even the Jane's point. So the primary entry point could be any of the following. But please remember, primary entry always is done in a flat position. Do not do a head low for the primary entry yet. And always try and enter with the initial trocar with the valve open, because the abdominal cavity is a vacuum. It has no air in it. And the moment you go in open and you pass through the peritoneum, the air will be sucked in and pushes the bowel away. Same happens with the entry with the Verres, entry with it open, not closed. Otherwise, you go into a vacuum and you will actually be next to the bowel and it will not be pushed away. You can consider an orogastric tube or a nasogastric tube for that matter if they had a difficulty during intubation and needed to actually bag the patient quite a bit. So you empty the stomach in such a case. We now go into port placement. This depends on the pathology. So you have your primary port and then you have your secondary ancillary operative ports. And this depends on the size of the pathology and what you're going to be dealing with. And also whether you are an ipsilateral surgeon or a contralateral surgeon. You have to keep ergonomics in mind to make it optimal at all times. Secondary ports are always done under vision and preferably only after Trendelenburg and with the valve closed, so that you don't have the gas leak out for the secondary ports. Always enter 90 degrees to the wall. Try not to go into the wall at an angle. So go 90 degrees to the wall And when you have tenting, then you can direct it to the pelvis so that the port is free to move around as opposed to an angled entry. And as we've said, with a closed valve. So what are the critical steps of TLH? The critical steps that are necessary for a successful TLH would be, number one, having the right team. So the right team here would mean having a camera assistant, a vaginal assistant, equipment handlers outside, the runner and the scrub team, and obviously the surgeon and the anesthetist. This reduces hanging time if everybody knows what they're supposed to do. So the team should be in place and should know exactly what to do. Critical step number two is equipment and the right instruments important? Yes, but you barely need advanced instruments for a good, clear total laparoscopic hysterectomy. A bare minimum is actually very okay. You could do a hysterectomy with just simple bipolar and scissors and with one or two graspers. We don't need anything fancy to do a hysterectomy. Once you've done that, obviously the next step in the procedure would be about restoring the anatomy and exposure. So you have to have a good exposure if you want to continue with doing the procedure in a simplified and straightforward way. If you don't have good exposure, then there will be a problem about the time taken and the risks that you're likely to expose this patient to. We go down to the actual procedures now. The actual procedure, one of the critical steps would be the tubo-cornual structures. Now we know there is the tube and the round ligament anterior and the utero-ovarian ligament posteriorly. However, there is a fourth structure which is very critical, and those are the subtubal vessels. So if you don't take care of that, this is an area that really can disturb and bleed quite a bit. Number one, that's the cross section. So tube, round ligament, and then behind we have the utero-ovarian ligament and the vessels in the middle. You have to get all these and preferably take them one by one. Always try and take them slightly away from the cornual area, roughly around 1.5 to 2 centimeters away, so that you're not very close and digging into the uterine muscle where it starts bleeding from, and then you actually will have a disturbed view every time because of bleeding. Once you've done that, then you have cut these four structures. The next step would be either the anterior UV fold or the posterior peritoneum. So let's say we start off with the peritoneum. The tip would be you only lightly coagulate it after pulling the peritoneum off the uterus, and don't buzz a lot. Lightly coagulate and cut, lightly coagulate and cut with the direction towards the uterosacrals. Caution here would be the uterine vein, which is likely to be encountered and can really be disturbing and bleed. And caution with the ureter. But as you separate this peritoneum, the ureter actually peels off and away. Now, after you've done that all the way to the uterosacral ligament, then you can go anteriorly to the UV fold or the vesicovaginal space. So in this vesical space, you would mobilize the uterus cranially and a little bit posteriorly. You will have your assistant use atraumatic forceps to hold the bladder, not the peritoneum, but the bladder. So you can fold up and hold the bladder and lift it up. You cut open this peritoneum just above the arcuate line where you can seal the fold, especially in patients who have not had a previous surgery. Not too high because you'll enter into the uterus and start causing bleeding, and not too low. Then you will use the bubbles or the cobweb appearance or the champagne appearance, as different people have called it. And these bubbles will actually guide you to dissect. In a previous scarred uterus, UV fold that is seen in previous cesarean section, for example, you would use the lateral window technique and not directly attack the adhesion. So you dissect it off from the anterior to the round ligament and find a space in, and then dissect below. Finally, on both sides, make these two teams, keep the bladder away, make them meet, and then go to the center and push it away. Because if we don't do that, you have a higher risk of injuring the bladder. Keep in mind the bladder pillars, which are the vesico-uterine ligaments laterally at the end, because they are vascular and can bleed. And please remember, traction is very important in this step. Without good traction, you'll not be able to dissect this place blood-free and in the right planes. And push this UV fold and the bladder to below the cervix until you enter the vagina. So you'll see a difference in the blood vessels over the cervix and over the vagina, where they are more linear. So you can tell the glistening surface of the vagina with those straight linear vessels, and you can tell now we are at the vaginal area. So this is step number 2, which is critical, with the tips involved there. The next step, after you've done the posterior and the anterior, is to skeletonize the uterines. So in this position, you would actually orientate the uterus cranially and laterally away from the side that you want to operate. You have to skeletonize the vessels well, because it makes it very easy to buzz the vessel directly than to buzz the vessel in bulk with the surrounding structures. Once you have isolated it well, it actually allows better bipolar control of the blood vessel. Then you take off, once you have buzzed it, you buzz it off the cervix, as we have said. So when you're buzzing it, and directly perpendicular to the cervix internal os. And once you've done that, you cut it and you take the vessel off the isthmus of the cervix and push it slowly downwards. So you would cut that way and then vertically down along the cardinals. Try not to cut into the cervical tissue, because the moment you go into the cervical tissue, you start bleeding again, and your planes will be wrong. You'll not get a good plane of separation. Next critical step, the cardinals and the pericervical fascia. In order to enter the intrafacial plane, you'll have to go now parallel to the cervix downwards in the pericervical area. You have to go flush to the cervix, but not into the cervical tissue, and go just below the cervical slope. So the vagina will be like that, and you'll feel a bulge before you go there. That bulge all around is the cervix. So you just go beyond the cervical slope. That's a guide to knowing where you have to open. And the other guide is from the uterosacral entry. When you've gone below it, you can now, the tip of the uterosacral, you can cut and open the vault just below the entry of the uterosacral into the cervix. Cervicovaginal vessels need to be kept in mind here, and you have to coagulate these and the entry of the uterosacrals and then section them. You have to, at this point, revisit the bladder pillars and adjust and push them further downwards, and it's at this point that you can open the vault. Now you can open the vault directly in this way, or you can open the vault over a colpotomizer, which you put in and delineate the phonesis. So when opening the vault, how can you open the vault? You can open it up with a monopolar hook, which with minimal settings, and using the cut mode, the yellow mode, not the coagulation mode. You don't want to coagulate this off too much. Be very careful with bipolar and scissors, because You could do this, but you don't have to over buzz it. When you buzz a lot and you stitch it this way, can give way and open up later because it could undergo necrosis. So use less energy on the vault. So monopolar hook with the cut mode in low setting is very good. Bipolar with just a little bit of precise short bursts of energy and cut is fine. Ultrasonic is also equally fine, or sometimes some people have done scissors directly, but I don't prefer that because it does cause quite a bit of bleeding. You have to insert something into the vagina as you do this to prevent the loss of pneumoperitoneum, and you open it from both sides, so from your side and then complete it from the opposite assistant side. You have to remember to change the direction of the scissors every time to keep close to the vagina. To keep close to the cervix so that you have very little loss of vagina. So direction of the scissors as you cut, just flush to the cervix is very important. And obviously, posterior then anterior is something that has worked very well with me, but it varies from practice to practice. But that's because when you start with anterior and then the uterus actually falls backwards, cutting the posterior can become a bit tricky. So I have preferred posterior to anterior because it gives me better access still. And occasionally pinpoint hemostasis should there be needed in those specific small vessels over the vault. Following this, the specimen is retrieved, which may be done in toto or in very big uteruses. You may have to do some little bit of lateral coring vaginally and pull it out. But then after specimen retrieval, the next critical step happens to be the vault closure. So we have different techniques, and different sutures that can be used. You could use the vicryl, you could use the barbed. You have a question about what kind of needle do we use? Do we use the round body or do we use a cutting needle? Well, a cutting needle makes it easier, but a round body can also be used. Then how do we support the vault to the uterosacral? Very important. Always keeping in mind that when you take a stitch, you have to make sure that the vaginal mucosa is taken in every stitch, in every bite, because if the vaginal mucosa is left outside, it might bleed outside as a post-op complication. Be very cautious with the angles. So the best way would be to start with one angle, take a stitch there, go to the other angle, start from there, and then come to close this side, rather than start with this angle and go through, because the other angle will be very difficult to close when you reach this end, and the angle might disappear inside. And if you unnecessarily go in deep without vision, you could actually strangulate or kink the ureter in that process. So angle, close the middle. You could do it as an interrupted suture. You could do it as a continuous suture, which is continuous, not locking. Don't pull together the vault into the center. So very important, don't tie them up into the center. It does cause dyspareunia in these patients later. So having it closed as a whole seal is better than having this and this tied in the center. Considerations during hysterectomy. Well, is salpingectomy at the time of hysterectomy necessary? I would say yes, very important. That in view of the history or the possibility that most ovarian cancers actually originate from the tubes. Once the uterus is out, there is no role of those tubes. Please do a total salpingectomy every single time, including the fimbrial ends. Don't leave the fimbrial tip. The ovaries need not to be removed in premenopausal women because they are still functional and produce hormones. If you leave the ovaries, they'll obviously be left hanging only with the IP ligament. So what is the role of adnexal pexy or uphropexy? It is important, can be done to prevent post-op torsion, or should there be a cyst formation in future and then you have a pedicle that could easily undergo torsion. So doing it to the ipsilateral round ligament is a good idea. What kind of suture do we use? Well, pexy is better done by using a non-absorbable suture like Ethibond, but even Vicryl is fine because eventually there'll be some fibrosis that will happen which will actually not allow that uterus, that ovary to fall off. But ideally, pexy should be done with a non-absorbable suture like Ethibond. Some other considerations. Why is the right ureter injured more than the left? And more so, why is it, with the especially right-handed surgeons who stand on the left side of the patient. So if you stand on the left side of the patient and you are operating as a right-handed surgeon, please understand that as you go to the right hand, because of the uterus here, your direction of cut might be more towards the lateral pelvic wall, because if you don't stay flush to the uterus, then you have a risk of injuring the ureter as you go lateral. So it's because of that that we have more injury on the right hand side. In open hysterectomies, it's the other way around. In open hysterectomies with surgeons who are right-handed, they stand on the right side and therefore they have more injuries on the other side, which is away from you. What are the safety tests sometimes involved with hysterectomies? Well, it is recommended that in all difficult hysterectomies, and make it a routine, it just helps, consider, obviously the role of safety tests like air insufflation with fluid in the pouch of Douglas for the rectum in cases where you've done surgeries near the rectum like endometriosis, etc. Consider bladder cystoscopy or filling with saline and methylene blue as well to see any mucosal breaches in cases of previous surgeries and you went very close to the bladder. In case of something like that, you may need to take a few stitches over that area. And for ureter, well, is there a role for stenting in suspected areas? What about ureteroscopy? And is ureterolysis really necessary in every case? Well, if it's a difficult case like an endometriosis, deep endo, then yes, you do not proceed with a hysterectomy without a ureterolysis and securing it. Complications of hysterectomy, well, it ranges from the anesthetic complications, complications due to pneumoperitoneum, complications due to surgical injury either in a normally located organ, or it could be in a dislocated organ because of adhesions and prior other issues. It could be diathermy-related injury, it could be patient-related injuries or complications like due to obesity, organomegaly, previous scars, hemorrhagic tendencies, ascites, medical issues, etc. And it could be post-op related to port site or shoulder tip or infection, etc. So this is how we would classify complications during hysterectomy. We'll be covering it in more details in actually a talk on complications in MIS. Thank you very much. So that was an overview of total laparoscopic hysterectomy and basically the critical steps involved in TLH. Thank you.